The broadcast is now starting. All attendees are in listen-only mode.
All right, so we are going to get started. Very special welcome to everybody who's tuning in to yet another EBFA webinar. If this is your first time tuning in, very special welcome to EBFA in our webinar series. And if you are a return attendee, then as always, very special thank you for continuing to support EBFA. So, as always, all EBFA webinars are recorded, they are archived, and they are found on our YouTube channel, which is youtube.com/EBFA Fitness. And what we're going to do is we're going to run through the webinar roughly 30 minutes, and then we'll do some Q&A at the end. So if you have any questions, you can write them down. There's questions box on the bottom of the control panel. So without further ado, we're going to get started to a very special webinar, Foot to Core Sequencing and Anatomist Approach with Dr. Kathy Dooley. And Dr. Kathy Dooley is tuning in from Australia, so I don't know if she picked up an accent while she was there, but we'll find out. Dr. Kathy is a chiropractor, an anatomist, SFMA. She's an NKT practitioner, level 1, 2, 3, and an elite instructor for NKT. And tonight she's going to give us her experience of the foot to core sequencing. And I really appreciate her background in anatomy, and I find it really fascinating. So without further ado, very special welcome to Kathy Dooley.
Thank you so much, Doc. I really appreciate you inviting me onto the webinar series. So let's get started on some discussions about foot to core sequencing. First of all, what is the core? A very hot button word, the core, and it means a lot of things to a lot of different people. From an anatomy perspective, this is how I look at the core. The intrinsic core muscles, these are the ones that are helping us to breathe 25,000 times a day, both in and out. They help us with abdominal compression for things like coughing and sneezing, defecation, parturition, or giving birth, as well as flexion and rotation of the trunk. So these muscles include the ones that you see to the right on Danny Cork's beautiful artwork here. Thoracic diaphragm, the pelvic floor, these things approximate for an inhalation. The ones below that are all exhalation muscles. If we move forward, we can see more core. And the core for that secondary are the muscles that function to help us keep stabilized. They're often considered extrinsic core, but I don't like to go that far. Just from an anatomy perspective, let's just take a look at some of these. The multifidus lumborum, these are transversal spinalis muscles. So basically they're back muscles that move the back, but they also help us to stabilize paraspinally. The glute max and latissimus dorsi, if you see to the right in blue, these muscles are connected to the thoracolumbar aponeurosis, a fancy hot button term. That means that we're connecting things that are intrinsic core to things that are on the outside of us. The lat works with the opposite glute to push us through gait. Erector spinae keep us upright, also attaching to that thoracolumbar fascia in the back. And then two important muscles that are the true pelvic muscles that are borders are piriformis and obturator internus. And if you see in the picture above on the pelvis, these muscles are coming from sacrum and pubis respectively, and these muscles are very important for ambulation, but also serve as secondary core muscles. As we progress forward, we can see that the core is not just muscle connections, but fascial connections. We have rectus sheaths. The rectus sheaths are aponeuroses, the fancy word meaning a broad, flat tendon that connects a muscle to another site. The rectus sheaths are formed on the front and back of the rectus abdominis by the anterolateral abdominal muscles like the obliques. So you can't just fire your six-pack, you have to fire everything at once. And if they don't sequence well, things do go awry. The inguinal ligaments formed by one of your oblique muscles and has intrinsic connections and helps us to force transfer from our abdomen down to our limb and vice versa. And then the thoracolumbar fascia, where if you look to Danny Cork's art to the right, he shows a laminectomy and cuts all the way into the spine. As you look to the left and right of the laminectomy, you see the thoracolumbar fascia and all the muscles it connects. So the core of us really spreads out to all of us, both upper and lower extremity. You can see that, I think, in the picture that's next. Yes. So if we think of the core being the trunk of us, and I'm being very arbitrary with that for a reason, we see the arms don't really help us to ambulate. We evolved to kind of be upright, to be bipedal. So we rely on our feet to contact the ground for the most part, and we are rooted into the ground. I really like this picture because it shows not feet itself, but how we are rooting ourselves into the ground with our lower extremity. It becomes problematic if we can't root our feet or if we lose this core sequencing, and those things we will find are intrinsically linked. As we progress forward, we can see the foot itself is 28 bones on average, a massive amount of bones. We have 14 phalanges. These are the distal parts of your digits, 5 basic metatarsals, 7 tarsals on average, and 2 very consistent sesamoids, which are sesame-like bones, usually embedded within tendons. We have a ton of bones for a reason. This foot needs to adjust to its environment, needs both mobility, stability, and a lot of sensation. As we move forward through the gait cycle, there's a contact phase, that often people call a heel strike, and then a mid-stance phase where the entire foot, as much as possible, can contact the ground, contacts the ground, and then we propel off of the toes or off of the forefoot to be able to initiate the next gait cycle. So, complicated components of foot movement involve supination and pronation. From an anatomist perspective, what we think about is on the heel strike, we actually come into this moment arm of dorsiflexion and then have to move into something called supination. So supination is kind of married to 2 different actions of moving from dorsiflexion to plantar flexion into inversion. And inversion is where the sole of the foot comes inwards. So plantar flexing means the foot kind of gets pointed towards the ground. Dorsiflexing means the toes are brought up towards the ceiling. So we go from toes to the ceiling, toes to the ground, and then roll the foot to the outside of the weight to the outside of the foot. The muscle that's largely helping to propel us at that phase is the tibialis posterior. This muscle is in the deep part of the calf on the very back. It's very hard to palpate. It's posterior to these gigantic gastrocs and soleus muscles that are more superficial than most of us think of as our calf. For mid-stance, we have to shift our weight from the outside of the foot for supination, move it into the majority of the surface that contacts the floor. And this is different for most people for reasons we'll talk about in a second, but we want to be able to mediate the amount of ground contact force we have with the foot by shifting from supination then into our third phase of going from mid-stance to toe-off. And that's pronation. Pronation is largely mediated by the peroneals or the fibularis group of muscles. And when we move our foot to the inside, our weight projects from the first metatarsal and out, propelling us into our next stance of gait. So if the gait goes well, we go from heel strike, from a dorsiflex foot, plantar flexion inverted, across the surface of the floor in mid-stance, go into pronation and toe off. And this system works really, really well when it's great, when it actually is able to adjust to its stimulus and be able to move through those phases without much interruption. The problem arises when we don't feel that ground contact with the floor, or there's some other type of issue up the kinetic chain that throws us off our kilter, and then gait can not go well. Here's some things that cause gait to go badly. Shoes that are not really designed to feel the ground. We actually have a bundle of proprioception or position sensing on the bottom of our foot. It turns out we need to feel the ground with our feet, but if we stick the shoe that we have on us in more of a heel, or we have flip-flops or some type of lift in the back of the shoe, it becomes quite problematic. We can't quite tell where we are in space, and we can't shift from those 3 parts of the foot contacting the ground in gait. People sometimes have a tendency to toe walk. They walk on their forefoot or shove the weight into the front of the foot. Some sports even promote this, like soccer, leaving them a little bit more susceptible to injuries. Tendencies towards heavy heel striking. People that have a disc herniation, usually in the lower lumbar spine or upper sacral spine, you can hear them hit their heel very hard on the ground. This is going to interrupt our good quality foot movement. If you have nerve damage like foot drop or a systemic disease like diabetes mellitus, you might not be able to even feel the ground very well with your foot. So this can make gait go not well. Orthotics are a very hot button issue. When we're talking about gait and being able to feel the ground with your foot, an orthotic actually makes the wearer accommodate to it rather than your foot accommodating to the environment. So that can actually interrupt the gait mechanism and make things show up higher in the kinetic chain. Improper foot transitioning in gait phases happens quite a bit. We'll get stuck in supination or stuck in pronation. Ways that you can help to measure this are things like single leg stance analysis, both in swinging and in static phases. If you see the foot fall into pronation too much versus supination too much and not be able to balance on the ground, then there may be an issue in sequencing. As we progress, we'll see here that the normal directive of force from the heel to the outside of the foot, across the foot, over to the great toe and off, if that's interrupted, then your stability might be altered for all the reasons we discussed, and I'm sure there are many more, but those are some hot button ones. This not only really creates problems in the foot, but can also create immense problems up the kinetic chain. So whether it's a core sequencing or core firing timing issue affecting the foot or the foot affecting the core, it can definitely go both ways, and it will show up in some different type of patterns that can even include injury. So I wanted to give a couple of examples of why you might see this in your practice, whether it's personal training or if it's even in a chiropractic office or a physical therapy office. You might see someone, when they stay too long in heel strike, they actually stay in that supinated position like you see in picture D. If you have them lift up the opposite leg in a single leg stance and you watch them push all their weight to the outside of the foot after heel strike and don't have the ability to come into mid stance and be able to push their foot through the middle of the foot, then this actually makes the tibialis posterior overdo its job. And this can alter its functional opposites at the hip, like the psoas and rectus femoris, preventing proper hip flexion for a lot of our swing phase and gait, and also for the eccentric loading when we have to actually maintain a mid stance. So this is how the foot can affect the core. And if the foot turns off a muscle that's so intrinsically important, like the psoas, then there might be an issue in being able to stabilize yourself on a surface. So just to recap, tibialis posterior chain muscle, the psoas, an anterior chain muscle, and the foot affecting the ability at the hip to be able to stabilize and gait. Another example, if the foot spends too much time actually in pronation, if we're rolling too much into a pronated position and the foot's kind of falling onto the medial side of the foot, this action is mostly mediated by the peroneals, the lateral part of your calf. And that lateral part of the calf, as you see in the picture to the right, is affecting muscles in that same lateral line that are up at the hip. And one such muscle was included in your core sequencing list called the gluteus maximus. The gluteus maximus has connections to your intrinsic core via that connection to the thoracolumbar fascia, that big diamond of fascia in the back. And if you're using that calf more than you're using something so incredibly important as the glute, it might show up in gait. The glute being very important for hip extension and being able to move in an eccentric load into heel strike. So just to recap, the peroneals, a lateral fascial line muscle that moves body weight to the inside of the foot, whereas the glute max, its major job is to keep weight on the outside. You have a small little brother like the peroneal trying to inhibit a very large, most powerful muscle of the body, and not mistakenly a core muscle. The core point, the foot being able to affect the glute max. So foot becomes so crucially important for core stability. As we move forward, some things that you might see compensating for the foot affecting core sequencing or core timing might be a loss of balance on the single leg stance. You might have someone that you ask them just to pick up one of their knees and hold it up to their hip, and they might not be able to do that. In any given moment throughout the day when you're walking, you are walking on one leg. And if you're running, there are moments in time where neither feet are contacting the ground. So you better hope that when you're walking those 10,000 minimum steps a day, that you're walking on a stable platform. The widening of stance and gait and exercise. I see this a lot, especially since I'm a kettlebell enthusiast with Strong First, and I do see a lot of people make their gait really, really wide. They'll widen out a squat or widen out a walk to be able to feel balanced. You might see this in someone with inhibited glutes actually waddle in the coronal or frontal plane. And you might want to suspect to narrow their gait and test them and see what's happening at the foot and how that might be affecting core sequencing. Toe gripping on squat patterns. Holy mackerel, I see this a lot. People that I ask them to even initiate a squat and they're gripping the ground with their toes. This is using muscles in the back of the calf, like the flexor digitorum longus and the flexor hallucis longus. These muscles not only grip the toes, but they're posterior chain muscles. So they love to shut off core muscles like the psoas and the glute max, preventing you from properly stabilizing at the core and wobbling on an unstable platform that is your foot. The toe flaring on a deadlift pattern. By deadlift, I mean more of a hip hinge, so the buttocks go back. On a squat, the butt goes down. They're very similar, but on a deadlift pattern, it's more of an emphasis on the back of you, the posterior chain. So what you see here is the toes actually flare up to the ceiling if someone can't properly shift the weight across the entire surface of the foot. They will flare the toes trying to activate the anterior crural compartment, the anterior calf. And because they have an inhibition up higher in the core, it happens all the time. We see this toe flaring pattern on deadlifts. If that's the case, then definitely think about how the foot is affecting core sequencing. The trunk and hip rotations on lunging, squatting, gait. Holy moly. If you see them into a single leg stance or a half kneeling and their trunk or hip are rotating away from the center, definitely suspect that there's a core sequencing issue. You should be able to keep an upright body in either of those sagittal plane events, like a half kneeling, a squatting, a lunging kind of gait. Even if you're just having them doing single leg stance, you should be able to see a lack of rotation, but more of a static type of posturing through the trunk. The trunk is something that should sequence first in any kind of firing, especially the transversus abdominis. So we want to see the trunk be able to maintain stability and be able to sequence well by firing first and then allowing the limbs to move. As we move forward, we can see that there is help. If you are having trouble and not knowing where to start, you may want to start just by making sure those 26 actual movable and then a couple of accessory bones are actually moving in the foot. What I find with a lot of people is their feet don't move. People have feet hate. They don't like their feet. They don't touch their feet. They haven't looked at their feet in a while. And they don't move very well from the foot, whether it's the dress shoe they wear to work or the fact that they wear too many shoes throughout their life and never even feel the ground. Get their feet moving. There are videos on my site. There are videos on functionalmovement.com. So many foot and ankle mobility drills. I'm sure Emily's got a lot of advice for you on this. Please get those feet moving and making sure that that foot that's so designed for mobility can actually move. You don't have 28 bones on accident. There's a lot of bones there because it was meant to move and accommodate to stimulus. Get barefoot. And I know it's the Evidence-Based Foot Academy. I hope that Emily would agree with me on this, that not enough people spend enough time barefoot. And I think that they can't feel the ground. They spend so much time in a shoe that with a lot of cushy padding on it. A cushy padding on a shoe makes for a cushy body, in my opinion. We want to make sure that we can adapt and change. And if we can't feel the ground, the odds are we're going to adapt slower and interrupt our core sequencing because we can't feel the ground. So getting rooted. Remember that picture with the tree. We want to make sure that you know how to feel the ground with your feet. Breathing drills for core sequencing. A lot of people don't know where to start with the core, and they want to go for like crunches or sit-ups. And I'm not trying to negate those things as functional, but you breathe 25,000 times a day. So you might want to make sure you're doing that well. So if you're looking at your client or your patient and you don't know how to breathe, watch a baby, watch a puppy. They are breathing from the gut because you're designed to use your abdominal muscles for breathing 25,000 times on average a day. So if you're breathing well, you might be able to core sequence a little bit better. So it's a great place to start. Regressing gait drills for balance. I know it's always hard to regress if you're an advanced athlete. It's hard to go from a long distance to walking again, but I don't know. Sometimes I'll put someone into a slow walk where I'll just make them go from heel to toe and slowly walk for me and they fall over and they're an advanced athlete. So maybe just slowing them down a little bit and just watching them walk and how they actually make a strategy for walking might give you a lot of information that can be very, very helpful to them. Foot dialing. I have a video of this on my YouTube series as well if you're confused about it, but foot dialing is not gripping the ground with your feet. Foot dialing is actually learning how to spread the foot and anchor and root the foot into the ground without flailing the toes, without gripping the ground with just the flexors of the toes, but actually dialing the foot in to the ground to be able to get some rooted stability and get more contact, more surface contact of the sole of the foot with the ground. And then, of course, if you have issues, don't wait. Get assessed and corrected. Don't wait till you have pain even. If you are falling over in a single leg stance, get yourself assessed and corrected by a professional, a quality doctor of podiatric medicine can help you, not unlike Emily and the rest of the members of the Evidence-Based Foot Academy and their enthusiasts. But I also included a list of people like myself that are really interested in gait. If we go to the next slide, you can kind of see a list of things I started. It's not limited to this, of course. It's just a starting spot for some people that want to learn more about foot and core sequencing. The selective functional movement assessment, Greg Cook's company is just fantastic. Functional movement systems is for our personal trainers that are not dealing with mostly pain. SFMA is more for people dealing with pain, like physical therapists and chiropractors. DNS works with reflexive stability. So if you're having trouble teaching someone how to breathe and how to move through basic stability, they work with neurodevelopmental patterns and they really know what they're talking about at the Prague School. So you might want to investigate a practitioner or even their seminar series to take for yourself. Neurokinetic therapy, not only plugging it because I am biased and I'm an instructor for them, but if you want to see how we work, and we deal a lot with gait, that might be a seminar worth going to, or seeing a practitioner certified in KT. Anatomy in Motion, Gary Ward, his seminar series. I have to admit, I haven't taken it yet. I've taken it in May, and I'm so excited about it because he goes from the ground up with the foot and showing how it shows up all the way up into the occiput and head movements. So might be worth talking about with foot and core sequencing. And of course, anatomy trains to learn more about how the anatomy works in fascial lines. If you are having trouble studying anatomy, I mean, I've dedicated my whole life to it, so I may make it sound a little easier at times, but you have to know that it was never easy for me and still is not easy, and I am studying all the time. So you got to start somewhere. So a great place to start would be anatomy trains. And if I can help you in any way, I hope that you'll check out my website, and it's drdooleynoted.com. I do daily posts on just health and life, and then I have a set of rehab videos on YouTube. It's just Dr. Dooley Noted is the YouTube channel. And maybe I can help you out in some kind of way. If not, I'd love to help point you to somebody that can. There's a ton of references for you. I've got just some basic peer-reviewed literature to support some of my thought processes, as well as some links to everything from links to different articles about foot and gait, and also to the artwork. That some of the artwork I used was really well done, so I wanted to add that as well.
Okay, excellent. Thank you so much, Dr. Dooley.
You're welcome.
If anyone has any questions, this would be the time to type those in under the questions section, and then we will go through those. I have a question just, to kind of get the wheels turning. You had mentioned as far as if you have, let's say, an overactivation of, like, say, the posterior fascial chain, and that can inhibit muscles in the anterior fascial chain.
Sure.
Is that almost, for those who are not like in depth with like the fascial lines, but maybe learned anatomy from like a altered reciprocal inhibition, which I know from being in fitness over 12 years before medicine, is that's kind of like the NASM way of looking at corrective exercise. Would you
Hmm.
say that it's kind of in that same line as?
I would say that's a definite starting point. I think it's not limited to functional opposites, but I think it's a great place to start, especially when we were talking about supination. Tibialis posterior being a posterior chain calf muscle that's close to the ground, and psoas being an anterior chain muscle that's up at the hip. Absolutely, that is a reciprocal inhibition type of event with functional opposites. I can't say that it's always limited. I see synergists blowing out synergists all the time, and even a muscle on one side of the body overacting for something that's on the opposite side and shifting the weight to the opposite side. But I would start definitely with reciprocal inhibition and looking at those patterns. It will help a lot.
Okay. And then I have another question before.
Yeah, sure.
Other questions is so then do you, just because you're so in anatomy, is do you, and with all your background in different techniques, is do you believe that so if you say somebody has an overpronated foot, which means they have overactivation of their perineals, and how that can lead to inhibition of the glutes, so that was
Yes.
one of your examples, um, can you then say, because just from a podiatry perspective, the way that we would learn it would be from like a joint coupling. So you're saying
Oh, yeah.
pronation drives eversion, which drives internal rotation, which then it's that excess of internal rotation that's what is shutting off the glutes. Or do you?
Yes, ma'am. That is me saying the exact same thing. And that is honestly, that is a beautiful way to approach learning what's happening at the foot and how that's affecting things up high. And that's regional interdependence. That is Carol Levitt's work. That is lovely. The fact that you are able to put that together, and I hope the listeners will do that too. Just put yourself in that patient's position or client's position and see how pushing that foot in medially and rotating in the internal rotation, how that just makes it very hard for the lateral rotators to support you in gait.
Hmm. So do you think that there's many ways to come to the same end conclusion,
Oh, isn't there always?
or is that
Yes.
a demonstration integrated the human body is from joint coupling to neuromuscular perspectives to fascial lines, and if somebody, let's say one practitioner goes about it one way from another practitioner, but the end result is the same, I mean, I guess that's just,
Yeah.
it's not really a
I
question,
mean, I
it's more complexity of.
no, that is a great statement that probably should be on a plaque somewhere in my office.
Yeah.
I don't care. I don't care how it gets done as much as I care about it being safe and right for the client and getting the right result. I mean, if the end result is the same, then the pathway to get there can be a path of least or most resistance. But as long as the results get there, yeah, just start somewhere and analyzing that foot and realizing that the problems at the foot are not just at the foot, but that they affect things all the way up the kinetic chain and vice versa can
Yep.
be a beautiful place to begin, no matter which direction you go.
Yep. 100%. Okay. So we got some questions. So,
Okay. Yeah.
first question was asking if there's a recorded version of the webinar. Yes, 100%.
Yes.
Sorry, that's not a question for you. um, all webinars are recorded and they're found on the YouTube channel, which is youtube.com/EBFA Fitness. So catch it there. Great question is, how do the smaller muscles of the foot turn off the core, or maybe they turn them on? So I don't know if she means like the interossei and the lumbricals, or more like the
Okay.
hallucis, etc.
I mean, for the same reasons we discussed, I'm not sure, am I directing her directly or no? Okay, whoever it was, let me just tell you that when I say toe flexors or toe extensors, I don't just mean posterior and anterior crural compartment like calf muscles, but of course the shorter range muscles at the bottom of the foot do play a big part. Neurologically, all of those muscles are innervated by the tibial nerve on the bottom of the foot. and on the top of the foot, the common fibular nerve. So when you're talking about spinal leveling, it's about the same spinal level on the bottom as it is on the top for a lot of things. So as far as the spine and brain are concerned, they don't really know it as well as you are developing the pattern for it. So when it comes to you using those small muscles, I wouldn't concentrate so much on thinking about the individual muscles themselves, like adductor or hallucis versus flexor digitorum brevis. I would start to think about, can I get this person to foot dial? Can I spread their weight across the surface of their foot and not get it stuck on one side versus another side? But if you check out my video on foot dialing, I think it'll help you out a little bit to understand how the foot spreading across the floor is actually the interossei, the lumbricals, every muscle on the bottom of the foot that's actually maintaining your arches. They're going to come alive. And you will feel your foot come alive, but you also feel your core come alive.
Okay, excellent. So there's a question. So is there a workaround or another way for clients who have orthotics for pronation but cannot be taped? This person happens to be a trainer and says that they cannot tape because it's out of their scope. So any like fitness
Oh,
recommendation outside of the orthotics?
of course, everything we discussed. I have to tell you, for personal trainer, whoever you are, I am allowed by law to prescribe orthotics, and I don't do it. So everything that I talk about on my series are things that you can borrow. You're more than welcome to go on my YouTube channel and see the foot and toe mobility drills, which would be wonderful. Uh, Definitely looking at them outside the orthotic and see if they are a true pronator, if they still need that orthotic. They might need another visit, an assessment. So making sure that you coordinate with their either chiropractor or physical therapist or doctor of podiatric medicine, whoever that you're working with or whoever they're working with for their orthotic. There's a lot you can do, and everything we just discussed in this PowerPoint can be very useful for you, because whether or not you're training them in the orthotic, you can change things up the kinetic chain that can help them just by teaching them how to breathe and helping them with core sequencing. That might actually prevent them from going into as much pronation as they're going into. Remember, it goes both ways. It's a two-way highway, up and down from foot to core sequencing. So I hope that you'll use some of these things we discussed. And there's absolutely grounds for use. I don't do any taping at all. My colleagues love it, but I personally like a proprioceptive rich environment. And I know as soon as you stick a piece of tape on somebody, they stop feeling it after a while, just like you don't feel your shirt right now until I brought it to your attention. So it's just if you're not into it and you can't do it, you can't do taping. There's a lot of things you can do, and I hope that you'll check out my website and get some ideas.
Okay, great. You also made a great point, Dr. Dooley, about doing a reassessment, where
Yeah.
I have so many patients who come to me and say that they are using orthotics because they are quote unquote pronated or flat feet, and I assess them and they do not need those orthotics. So,
Ah,
um, and that's as a podiatrist. So,
yeah.
you know, not necessarily trusting the client just because they're saying, you know, if and I teach how to assess the feet in my workshops, which trainers can do, and then kind of guide them to another practitioner who maybe is a little bit more open, such as Dr. Dooley was mentioning. So some food for thought. So I really like that you had said that, to get a possible reassessment. Um, okay, so another question said, in heel off or propulsion, is the foot supinated um,
Oh,
or
no.
pronated, or is it both?
No, neither of those things. If you're actually in the, like, you go from pronation into toe off. You have to, because the flexor hallucis longus, that is part of your win-loss mechanism, that pulley system for toe off. You have to go from the supinated foot, ideally, into mid stance and then into a pronated foot and then off of the great toe. But you actually, on toe off, are neither in pronation or supination. You move from pronation into toe off.
Um, okay.
Is that what they wanted to know?
I believe so. I think they were confused about the gait cycle and the foot position.
Okay.
So what about people who say they have pain without their orthotics? Um, that's the first question. And then the second
Okay.
question is, what are your favorite mobility drills for the foot and the ankle, which I think you kind of covered already.
Yeah. Again, with the orthotic, if if they have pain, I don't know who asked this question, but if it's not in your scope of practice to deal with pain, then you need to send them back to whoever prescribed their orthotic and get reassessed. If they have pain in their orthotic, then they definitely need a reassessment because it might not be a right fit. There might be an issue of some sort with the brand or the texture. There's so much going on with that. So I would send them back to their doctor to get a new orthotic or a reassessment at least of that. As far as the mobility drills, yeah, I've got a whole series of that on my YouTube. You're more than welcome to. I love working on forefoot, midfoot, hindfoot, subtalar, ankle mortise, the entire thing, and then integrating that into foot dialing. And so I will show you all that on my YouTube series. So.
Okay, excellent. So sounds like everybody needs to go to your YouTube channel.
Sorry, I didn't mean to do any like shameless self-promotion. There's a
No,
ton of stuff out there. I'm just a place to start, and there's so much out there. So, but definitely, I'd love for you to come visit me on the YouTube. But if not, there are so many people doing great things. But definitely make sure that you're assessing and looking at all 28 of those bones, 26 namely, and then assessing to make sure that they don't have, not stuck in one phase of gait.
Okay, so we'll take two more questions. Um, so, with a herniated disc issue, do you notice clients in a more supinated or pronated position during heel strike, but just kind of, I would say, in more like from a foot to core sequencing? What is the impact that you see a herniated disc doing with that?
That is such a good question. It depends on the level of herniation, but you're going to get like foot slap of the floor and something like a foot drop, like an L5 situation, versus a heavy heel strike on like an S1 disc herniation. Um, but I like what they said about core sequencing because a person with a disc herniation most likely has really poor core sequencing. And I say that just from my experience of knowing that if you move the lumbar spine too much, guess what happens? You herniate a disc. The lumbar spine is meant for stability. It's not meant to flex and rotate. It's not designed for it. It has sagittally facing facets. And it is meant to be, of course, it moves, but not under load. We don't want it to move under heavy load, and we wanted to be able to maintain stability. And who keeps us in lumbar stability is this core, intrinsic and extrinsic. So if they have poor core sequencing, which it sounds like they do if they have a disc herniation, that's a great place to start. Watching them breathe, watching them go from sit to stand, watching them touch their toes, put them through a movement screen of whatever you have in your box of tools, and see how they manage that. And of course, in single leg stance, look for, I don't see more supination versus pronation. I see a global stability loss across the foot. It really does depend on the patient and depends on the disc level.
Okay, great. So we'll do one more question just kind of for the sake of timing. So, with pain in the foot, would you recommend NKT or an NKT assessment of the lower leg muscles in hopes of eliminating orthotic or foot pain?
Oh, if they said lower leg, I'm assuming that they have not yet experienced NKT because we do a global assessment in NKT. It wouldn't just be at the leg, but yeah, I mean, I'm biased because I'm not only an NKT practitioner, but I'm also an instructor. So I'm going to tell you yes. But yeah, I use NKT as part of my assessment, of course, as well as SFMA, FMS. And then my skills, my correctives, I use a lot of stuff from FMS and Strong First. So I'm going to use what I know, of course. So I would say, of course, yes, please get yourself assessed and corrected by anything that I've listed are great places to start, including NKT. Absolutely.
Okay, excellent. So, if anybody has any questions that were not answered, or thinks of questions as they let this process and just kind of take in all that Dr. Dooley had mentioned, how can they reach out to you or find you? Facebook or? What
Yeah, Facebook. My Facebook is just Kathy Dooley in Astoria, New York. Actually, I think I've changed it to New York, New York, so people could find me easier. And then my email is drkathydooley@gmail.com. Pretty easy to find me.
okay,
So more than welcome to email me personally on either Facebook or Gmail.
excellent. And then your YouTube channel is it youtube.com/Dr. Dooley noted?
I believe so, yes.
Okay, excellent. So it sounds like we'll have to all check that out. Um,
Sorry about that, was the shameless self plugs there.
no, not at all. So again, just want to thank you, Dr. Dooley, for tuning in, especially from Australia when you have a little day off over there. So we greatly appreciate
Yeah.
it. And we hope to have you again on to another EBFA webinar.
Thank you for having me. I really appreciate it, Doc.
All right. Thank you to everybody who tuned in. Again, if you have any questions that were not answered, I greatly apologize just because of timing and some of the complexity of questions. Or if you think of some, please do reach out to Dr. Dooley. Again, all of our webinars are archived. And coming up in April, we're doing something special where we're doing 4 webinars where you can get CECs for them, which means there's one once a week and you earn CECs. Unfortunately, you have to pay for them. But we're doing something special, and that is a movement from the ground up webinar series from EBFA. So stay tuned for that, and otherwise, have a great night to everybody. Thank you so much. Thank you, Doc.
Thank you.